And I'm quite surprised to have those two questions here, because I thought we discussed it before, but I think the really crucial questions are not outlined enough until now. And actually one question is to the chair and to the last speaker, to Frank Nickemeyer and Eduardo Breira. Finishing hydration and feeding, isn't that euthanasia? Or let's see, assisted suicide? I want to add.
I think, thank you very much for the question. There's no doubt that if somebody is eating and drinking and we suddenly say, no, you cannot have your macaroni and cheese or your water, that would not be nice. So that could be seen as a little bit aggressive. But when we're giving hydration or nutrition by subcutaneous means, nasogastric means, gastrostomy means, etc., it becomes a medical procedure. And it has the same indications as any other medical procedure. So ultimately, it is a balance between, is this making the person feel better, or is this hurting the patient? That will help us make the decision that then that artificial feeding or artificial hydration might be appropriate or not. And so, no, by no means, once you make that decision that this hydration is only creating problems and not helping very much because the person is already delirious and progressively unresponsive and actively dying, it's just a very wise procedure to do. Same thing is when you are giving nasogastric feedings or G-tube feedings and the person is basically choking or is having no advantage, you decide that that medical intervention is not anymore justified. So I hope that addresses the issue. But my advice is don't take away the macaroni and cheese and the food, the drink of the patient, because that would not be nice.
Thank you, Ed. And Frank, do you have something to add briefly from the governmental or legal German view?
Well, from the German view, I mentioned if the patient previously clarified that he doesn't want nutrition or liquids, we have to respect that. It's only when there is no clarity about the patient's will, then another rule applies, and as we are in Rome, I may say it in Latin, in dubio pro vita. So in doubt, of course, you as doctors and nurses must nourish him and give him or her water. But if the patient decided differently before, after he was informed by a doctor, according to German law, we have to respect that.
And one to all of the table here, all presenters. The African concept of illness, spirituality, palliative care quite differs. Most do both Western and African care for the sick and family. This needs special attention in future meetings. Do you want to add something to different cares? The different views?
Yes. I think that's actually part of a much wider question, and that is how we ensure that we make appropriate generalizations from one setting into another, and how we are sensitive to the important differences. As you can tell just looking at me, I spent most of my childhood in Africa, and apart from being born in Malaysia. So I was very aware at that time that there were very contrasting interfaces. For example, seeing mission hospitals where the different cultures were meeting was often a source of these kinds of questions. But I find it equally, I do a lot of research on the healthcare system around palliative care in the United States. I think it gives us very good insights, largely about what we shouldn't do, but because things are very extreme in those circumstances, you get an insight into processes and mechanisms that you wouldn't get elsewhere. So I think really the onus is on us to be clever at drawing analogy, clever at understanding lessons from other settings, and never going down the road of saying one approach in one country can be generalized more widely.
And there was a special question to Howard Koh about the funding of spiritual care, really the practical funding.
So actually there are two questions here. The first one has to do with where do I think funding might come for spiritual care. Will it be from insurance companies, state funding, how? Question. So this term of alternative payment models that I've referred to several times is a very cutting-edge topic in American healthcare. And our Centers for Medicare and Medicaid Services, CMS, is the most important agency within the Department of Health and Human Services because they approve the reimbursement of certain payment models. And as I mentioned, traditionally it's been volume-based fee-for-service. In this era with so-called accountable care organizations and hopefully accountable health communities, if there's more emphasis on paying teams of providers to coordinate care, and if outcomes are good and there's savings, everybody shares in those savings. The term shared savings is used a lot. That could be an alternative payment model for the future. And in that second model, the accountable health communities, that's where I think the spiritual care issues could come in. We're seeing some of those cost issues come with evaluation of palliative care, and it's been very encouraging to see that from some of my colleagues because if palliative care is provided correctly, some studies indicate that unnecessary treatments can be avoided, and that could be a source of cost savings. So in short, more attention to these alternative payment models through the Centers for Medicare and Medicaid Services, their Innovation Center. If we can do those studies and prove those outcomes, improve quality, improve care, lower costs, and there are savings to be shared, that could be a way to go forward. The second question was asking a bit more about connectedness between burnout and spirituality. And I think this issue is just starting to get national attention in our country. Being a physician in our society in the United States is very, very challenging. I'm sure it's very challenging around the world. But in the midst of all the changes in healthcare, all the discussions about the Affordable Care Act, the introduction of electronic medical records, which has provided more stress to the system and to professionals, and the tremendous responsibility for physicians in particular. My wife is here, she's a physician. My daughter is not here, she's a physician. I'm a physician, so I'm very sympathetic to this. And we have some physician leaders in the audience from the United States. Lots of discussion about physician satisfaction, physician quality of life, and meaning and purpose in a physician's career and how to prevent burnout. We know that suicide is another challenge in physician groups too in the United States. We're very, very concerned about those studies. So the article I quoted was one of two in the New England Journal last month. The second one was from Dr. Victor Zhao from the National Academy of Medicine, who is one of the leading health policy experts in the country. So this issue is getting more attention. I'll be fascinated to see if this issue gets global attention, because I feel strongly that the more the doctor, the healthcare professional, discusses these spirituality issues and how it relates to themselves as well as their patients, I think the better off we're all going to be.
Thank you, Howard. So now, Thomas, you didn't have any question, but I want to say I learned something very, very important, to give the best for the poor. That's really important, and I would give you the chance to have the last words here. The last words are very important. But honestly, if you would like, I would like to hear another chant. No, as you want to.
Well, I hope it was as enjoyable to you as it's been to us. There's a huge amount of information available already about the fact that what we do pays the bills and that it can be adapted to different systems. We also heard that the measurements that we need to make are different in different areas, but the opportunity to go back home and argue aggressively for your program to include palliative care, and more importantly, to take advantage of everything you learned today to provide you with the references that will support that what we do pays itself, saves money, improves the reputation of your institution, and overall is an ethical and moral mandate. That gives you enough ammunition to start making the 15 minutes of glory miserable to your dean, the president of the hospital, and the basic so-called leaders that are actually the problem. So thank you very much.
Thank you. Thanks very much. Thank you.
What time do we go on? Photo? So, please, for a photo.